Thank you, Chair. I'd like to talk a bit about the workforce. We know there are gaps in the workforce. I don't want to pick that bit up because that's a future side. We're all in agreement on here, even government says we don't have enough staff. So there's a problem. We've got the next several years of how do we get the best out of the staff we've got. That's retention, recruitment and remodelling. Those three things are really, really important. So I want to try and break those down a little bit. So Dr. Kanani, if I could start with you. I could write as a GP a list of some of the fundamental things that could change and should change in a day-to-day GP's life that would make a difference. The question I find difficult is who is making that decision? Because it clearly can't come from a government minister because they won't have the insight of what it should look like. So who at what level? Is it yourself that would be making those decisions that could actually alleviate patients? And I'm happy to give some examples of things that could make a difference. But can you talk me through how the decision structure, because as yet we haven't heard there is a plan for the day-to-day making life better for a GP or someone who's working in primary care?
Thank you. So I'd probably start with the review of bureaucracy that's underway at the moment, which is a concordat review between ourselves, Department of Health and other government bodies. It looks at a range of things that would improve our working lives, our day-to-day lives in the way that you describe. So some things are things like our fit notes or DVLA checks, things that we have to sign off, don't necessarily sit within an NHS England or even a Department of Health infrastructure. Some things sit within our own space. So, for example, the primary secondary care interface, some of the things that we find most challenging day to day.
So I was going to say, let's pick that one up, a great one, because that's a prime example of hospitals potentially dumping work onto primary care. That would be the primary care argument. But equally, inappropriate referrals going back up and the use of proformas that aren't pragmatic. And there's different ones. I've worked in a multitude of different settings across the country, and they are all different. That can't be sorted out by government, but it can be sorted out by the NHS and the trusts. So these simple things, who is the decision maker and why isn't that being decided? Do you want to come in?
Because we've just been picking up that very thing. So there is a piece of work that the Academy of Medical Royal Colleges is going to carry out for us, which says, in a new world of integrated care systems, where a lot of the older perverse incentives around the behaviours and handoffs of patients between primary and secondary care should in theory go away. What's the reset for that relationship between primary and secondary care and how patients flow through pathways rather than being handed off? And you know exactly the things.
Let's pick that up, because COVID, we saw the pathways change overnight just like that. Absolutely fantastic. And everyone went, gosh, why the hell can't we do this? So I'm now putting that back to you, because already we're falling back into old style of bureaucracy decisions. Patient safety is absolutely paramount, but we need to be creative in the way in which we deliver. So, for example, is there a space in the contract to say that we should be paying for thinking time? Every person we've heard as a clinician come in has talked about, I had headspace to reinvent. That would be revolutionary for the coalface, because they're the ones who are going to solve the problems. Is there a way that we can think about putting that in place?
So you're absolutely right. We cannot expect general practice to transform the way it works or to remodel its workforce with absolutely no headspace to actually step back and look at it and put those changes in place. All of that takes time and work. I would like us to step away from an approach where we pay for specific interventions rather and look at an approach of what do we want general practice to look like, how do we want them to be able to deliver the best care for their patients. And as you know yourself, each practice has a different sort of patients, a different demographic, a different priority. So I think it's really important. We've got Claire Fuller's stock take, and we're working now to look at how we implement that. That's not a very quick fix. There's big asks around integrated teams, around estates. But nevertheless, that gives us a picture of what this might look like. We have to recognise we've got to give...
I'm going to pick you up on that, because that's really important. And this committee likes to ask the question, should we look for revolution or evolution? From what you're saying, you're prepared now might be, especially with everything going on outside this room, the time to be saying, actually, we should really rethink the way in which we do the contracting around GPs in primary care and the way the system looks, given we now have the integrated care system as a block to try and undo that. i.e. give responsibility back down to the ground to let clinicians be clinicians, let leaders be leaders, and let the politicians take the flak when it goes well or badly. Is that a fair assumption?
So I think we need a mixture of evolution and revolution. I don't think we can have a big bang where we rip it up and start again. But there are opportunities, as you know, each year as we discuss any changes to the contract to look at things we might want to put in place. And the current 5-year period of the contract finishes at the end of March 2024. So there is an opportunity to say what bits of, how do we fit integrated neighbourhood teams, primary care networks, and a much larger skill mix in primary care into how do we contract for what we want to see?
Is we you? Because we hear this a lot with people here. Do you feel you have the power in your position, or is that more the ministerial team? This is the question in the NHS. Who is the carrier of the risk and responsibility at this point?
So NHS England is the contractor at the moment, but we work in partnership with the Department of Health and Social Care, and it's not a single go, Matt.
So if I may, Dr. Evans, you made a point yourself that, of course, the creation of integrated care boards and they're becoming on a statutory footing from the 1st of July is a huge opportunity in this space. And I think the flexibility that integrated care boards now have to deploy their resources in a way that makes most sense for their local population. There are additional flexibilities in how the financial framework works that integrated care boards can exploit, partly in tackling some of the bureaucracy that you referred to earlier, but also in really engaging in the delivery of that fuller stocktake in order to ensure that, as you say, clinicians can make the decisions to design services that best meet the needs of their patients.
That point, sorry, you say you're going to give them powers. How many national targets are you going to scrap in order to give them autonomy to do stuff on the ground?
I think it's very well established that integrated care boards at the very heart of the new legislative framework that is now in place is
there aren't any plans, are there,
autonomy.
But there aren't any plans to scrap any of these national targets. So I'm just worried that autonomy you're paying lip service to autonomy, but actually they're going to be run on a very short leash, as you and NHS England and your former place, the Treasury, used to really enjoy doing. And basically, they're not going to have the freedoms, are they? They don't have any more freedoms than CCG's had.
I think it's entirely appropriate that we set some very clear national expectations for what we expect our colleagues in frontline health and care to deliver for patients. That's particularly important in the current climate. But at the same time, more flexibility within those targets for local leaders to set their priorities according to the needs of their local population is absolutely at the heart of our vision for how the health and care system will work over the coming years.
Really helpful. And the one final set of questions is the final about retention, and I'm going to raise this point again. Every senior doctor that we've come into contact raises pensions as an issue, and I've raised this with the Secretary of State. I understand the trade-off over very well-paid people getting paid extra to go and carry out. I get that. But fundamentally, we've got the biggest backlog we've ever seen in the NHS, with the most experienced people saying they're disincentivised to take on extra work. That's not them making it a moral judgment. It's just saying the practicalities. They're already burnt out. Why would you go out and not get paid adequately for doing so? I think that's a reasonable position to put in place. And Matthew, can I ask to you, do you still identify the pension issues as a problem? And what workarounds have there been put in place? There was a temporary measure put in place for 2019. We've heard that some NHS's trusts are putting in place the clawback, allowing people to write it off. Is that something you would put in to mandate to other trusts to get people to stay on to work? Or what other solutions have the department been working on to try and resolve this issue?
So, I mean, look, as the Secretary of State said when he appeared, the previous Secretary of State, said when he appeared before the committee previously, tax policy and pensions tax policy is, of course, a matter for the Chancellor and not for me. I do think that we do have a role to play, as you say, in terms of supporting local employers to understand the full range of flexibilities they can make available to support staff to stay in the active clinical workforce for as long as possible, and indeed to increase their participation rate. We have issued guidance already jointly with NHS employers on the range of flexibilities that are available. At the same time, I think it's at the end of the day, individual employers do need the flexibility to make the decision about which flexibilities are appropriate in their workforce. balancing the range of factors they'll need to take into account. Therefore, I don't think we should at this stage be mandating particular flexibilities. Our role is to, as I say, support employers to fully understand the flexibilities, and we'll keep. Sorry, Dr. Evans, we'll keep under review whether there are any further changes to sort of national rules that could be made to support employers to that end.
Really useful question. I appreciate that. There's a practical point. Every day that goes on is another GP who's saying, I'm not going to take on more work or looking to take retirement. That is the reality of what we're living with, and the same in secondary care. That has to be an active decision not to mandate, as opposed to a passive one to let it pass. Therefore, is there a timeline that you would be looking at to make a decision? I appreciate there's a new change in the department and this has to be a political decision. But is that something that's being actively discussed at this point to try and come to a resolution, given we're in the summer before we get to the winter, which is going to be a very problematic time if this isn't resolved?
Yeah. I mean, it very actively under review, and we are listening to proposals both that employers and workforce representatives will make to us, and discussing those across government. I think our track record in terms of acting decisively on this, as you say, we made some very particular steps in 2019-20 to alleviate this issue, and it's under active consideration.
Thank you. I'm